Hi, everyone. Welcome to today's webinar. My name is Melanie Fugaro, and I'm the Director of Marketing for Castlewood Treatment Centers. Quickly, I just want to mention, which I usually do in the intros of these webinars, is our Facebook Live Eating Disorder Recovery Series. So we have scheduled the remainder of the discussions for the year, and you can find them under the events page on our Facebook page at Castlewood TC. So the topics we created are meant to support your clients and their loved ones. And you can also find our previous recorded Facebook Lives on our website under the Resources tab. Before I introduce Dr. Siegfried, here are a few items regarding this webinar. At the completion of the presentation, we will have 10 minutes for questions and answers. Please type these questions into the questions box of your GoToWebinar screen, and I will read the questions to Dr. Siegfried to answer. You will get an email from Citrix about 1 hour after completion of the webinar with a link to an evaluation. Once you complete that, we will send you a CEU certificate 1 week from today. The topic of this webinar is matters of life and death decisions, assessing and treating suicide and eating disorders. Dr. Nicole Siegfried is a psychologist and a certified eating disorder specialist. She is our National Director of Eating Disorder Program Development for all of our locations and the Clinical Director at the Highlands, our Birmingham, Alabama Treatment Center. She is a member of AED and co-chair of the Suicide AED Special Interest Group. Dr. Siegfried has more than 15 years of experience working with patients with eating disorders and helping them transform their lives. So without further ado, I will now turn the time over to Nicole Siegfried.
Hi, good afternoon, and welcome to the webinar. I am very excited to talk to you guys today about this very important topic. As Melanie said, I've been treating eating disorders for a good while now, and prior to working at these higher levels of care, I had an outpatient practice. And like many of us, I had been trained on how to determine if someone needed to go to the hospital if they were suicidal, and how to contract for safety and that kind of thing. But when I started working in higher levels of care, I really felt ill-equipped to be able to treat these higher levels of chronic suicidality, really, that we see with our clients. So as many of you know, eating disorders have one of the highest suicide rates of any psychiatric disorder, and we'll talk about why that is. And so I just felt like what we were doing was sort of putting a Band-Aid on a bullet wound, so to speak, and so it was it became sort of my mission to do better work around that. I guess that phrase, necessity is the mother of invention, I felt like I needed to really hone in on how to understand suicide in this population and truly be able to treat it and help clients who are struggling with this very serious symptom. So that's a little bit of the history in terms of how I started specializing really in suicide and eating disorders. And earlier, like in 2008 or 2009, a colleague of mine that we presented a lot on this topic, Dr. Mary Bartlett, she and I began working with Dr. Thomas Joyner's lab and some of their students who have now gone on to have their own lab studying eating disorders and suicide. And so we've conducted some research in this area, some of which I'll be sharing today. So I have this slide in here. I think this is left over from another talk, but these are just some of our locations. And I'm at the Alabama location, which is down there in the left-hand corner. And actually, we are a partial hospitalization and IOP center currently, and are in the process of expanding to residential care here in Alabama and opening sometime next year in 2018. So that's very exciting. So today, what we're going to talk about is first the relationship between eating disorders and suicide and what is that overlap. And then we'll go into really understanding the suicidal mind. I say this all of the time when I talk about this, that if that is the only thing that you take away from this talk, that my work here is done. To me, this is the most important part of working with suicidal clients, is really understanding what is going on as part of being suicidal. And so today I'll kind of take you on a journey into the mind of someone who is suicidal. And then I want to help you guys understand a way to conceptualize eating disorders and suicide. Why is the rate of suicide so high in eating disorders? And so we'll go through an explanation of that. Then I want to spend some time on how to do a good suicide risk assessment. And I'll go over the suicide risk assessment that we use here at Castlewood. And it might be something that you want to integrate into your own practice. One of the things that I believe that Melanie sent out the PowerPoint presentation ahead of time. And if this wasn't in here, we will make sure you all get them. There are also handouts that go with this presentation, which will include a template of the suicide risk assessment. And then we'll go through interventions based on each level of risk. And so what do you do if a client is at low risk or a client is at high risk, etc. And then we'll have time for questions. So as you may be aware, suicide rates in eating disorders are 23% higher than in the general population. Specifically in anorexia, there's some studies that show that individuals with anorexia are 61 times more likely to die by suicide than the general population. In bulimia, we know that individuals with bulimia, 1/3 of them will attempt suicide at some point in their disorder. In binge eating disorder, there actually hasn't been as much research on suicide rates in binge eating disorders, and partly that's due to the fact that it was not identified as its own separate disorder until more recently. But some recent research does suggest that there are definitely higher rates of suicide in binge eating disorder than the general population, but more research needs to be done in this area. So as one of your handouts, you have a list of all of the myths and facts related to eating disorders and suicide. These are just a few of the highlights. Some of these come from Thomas Joyner's book, which is called Myths About Suicide. I highly recommend both of his books. Well, he has several books, but both of these books, Myths About Suicide and Why People Die by Suicide. They're both very user-friendly guides and even helpful for family members, not only professionals. Dr. Joyner has a very interesting perspective because he comes at this from a research perspective and clinical perspective, but his father also died by suicide, so he also comes from it from a personal perspective. And so that compassion and understanding is interwoven throughout both of his books. So these are some of the myths and facts that are related to eating disorders and suicide. One of the myths, of course, is one of the things we know is that individuals with anorexia specifically are very harm avoidant. And so mistakenly so, some people may think that these individuals may be protected in terms of violence against themselves because they're very harm avoidant. And actually, that's not the case. We'll talk about this, but that individuals with anorexia choose very violent methods of suicide attempts, and the reason for that may be habituation to higher and higher and more violent levels of self-harm, and we'll talk more about that. One of the other myths is that maybe individuals with eating disorders die by suicide because they're already so compromised, and so so that it just, this sounds bad, but that it just doesn't take as much to kill them, so that because they're already so compromised. So if you or I took a certain number of pills, it wouldn't kill us, but someone with an eating disorder, maybe it would kill them. And actually that's been shown to be a myth, because the means that have been used for individuals that die by suicide with eating disorders are very violent, very lethal means, and that is why they're dying by suicide. So you can see some of these other examples that are listed here, and then you also have a list yourself of in your handouts that go into greater detail. So, like I said, one of the things that I think is so important in working with clients who are suicidal is truly understanding the suicidal mind. Ed Shneidman was actually the first suicidologist, which is a fancy term for someone who specializes in the study of suicide. And he has some really beautiful quotes that depict what it's like to be suicidal. And one of them is these: every suicide makes this statement, "This far and no further." So in understanding the suicidal mind, there are several high points that we can hone in on. First of all, individuals who are suicidal experience something that's called psychache. I love that term, and sometimes just being able to share that term with and give clients that nomenclature, vernacular, is helpful, because there sometimes feels like there aren't words to describe the psychological pain that they're experiencing. And psychache is a term that Shneidman coined to describe that psychological pain. That psychological pain is so great that they'd rather endure the pain of death to escape the pain of living, really, that is associated with that psychache. Sometimes you'll even see clients kind of hold their heads as they're describing that psychological pain, because it's sort of a torrential downpour of psychological torment that is feels inescapable. And so helping them be able to put some words to that by itself might be a helpful intervention. We also know that individuals who are suicidal experience three characteristics, more than that, but these three main characteristics, and we'll go into these in greater detail because they're part of Joiner's conceptualization of suicidality. The first, individuals feel like they are burdensome, and this burdensomeness can take on sort of what I say different flavors, and so I'll go into that in a moment. They feel disconnected, they feel isolated, and feel like they don't belong. And they develop a fearlessness regarding death. And so we'll talk about that a little bit more. Joiner refers to that as an acquired capacity for lethality. And so we'll talk about the factors that go into that. One of the characteristics of individuals who are suicidal that I think is so important and can be important in talking to clients is understanding this idea of constricted thinking. So I'll often explain this to professionals and to clients as sort of what happens in a fight or flight response. So as we know, during that time, when you're highly activated, like you see a bear or something like that, your mind zones in and you get sort of tunnel vision, which is very adaptive in that situation, so that you can just focus on the bear, so to speak, rather than all of the other extraneous variables. And so this is a very adaptive phenomenon in those situations. Well, in suicidality, this same thing happens, and it's not particularly adaptive in this situation. It's your brain's attempt to be adaptive, but what happens is that thinking gets so constricted so that you're not able to see other ways out, and the only option is to see, death seems like the only option, and everything hones in on that choice point. I think about it often as being in a burning building, and when you're suicidal, you're in that burning building and you don't see any way out except to jump off of the roof, and the alternative is to sit there and burn to death. And so the the irony or the tragedy there is that clinicians, I always say, we have a map of the building and we can see all of these exits out of suffering. We see all of these escape routes that the client can't see because the smoke is so heavy, and so they only see jumping from the building as their only option. So I talk about this with clients all the time and validate that their thinking is constricted and it's their mind's attempt to escape this pain, but that actually it's a maladaptive process, or it's an adaptive process, I suppose, that's gone awry. So I'll often say, and when I have good rapport with a client, I'll often say things like, the worst time to kill yourself is when you're suicidal, because right now you're not thinking clearly. Right now you're only seeing this one exit out by jumping from the building, and we need to wait for the smoke to clear. Or I might say that I have a map and I can see these other ways out, and so right now you have to trust someone else who sees other options. So sometimes I've had clients who really hold on to that and are able to even just sort of have that mantra, the worst time to kill myself is when I'm suicidal, as a reminder during that constricted thinking. So that's a very important concept. If you can take that away, that could be very helpful in treating your clients. And then the last thing that I always like to talk about is that suicide attempts are not attention seeking. And in fact, I sort of bristle when someone says, oh, she's just doing that for attention. And I don't exactly know what that means. I mean, I know what it means, but I don't know how that's helpful. And I've even said sort of sarcastically before, I don't know if we'll care if when someone's died by suicide, if they were doing it for attention. That does not should not stop our intervention, which I think is what happens, is that when people think of this as something that's being done, quote, for attention, that it's sort of like, well, she's not going to really do it, or it's not going to, or he isn't good, it's not going to really mean anything, and so we don't have to do anything. And so that's a big mistake. So I try to help clinicians think about these attempts as more help-seeking, that when you don't have the words or you don't see any other way out, this is the option that's chosen. So just to think about it in that way. So these are some of the voices and some of the things that clients have said who have eating disorder and are also suicidal. And you can see sort of the interplay between the suicidality and the eating disorder and how those overlap for clients in different ways. So this is a client with bulimia. Sometimes I feel like even if my eating disorder goes away, I'll still want to die because I've always felt that way. That makes me wonder if recovery is even worth it. No one understands that my eating disorder actually keeps me from committing suicide, because when I'm starving, the urges to kill myself aren't as strong. Someone with anorexia. Someone with binge eating disorder. I was bullied for being overweight from age 11 until the 9th grade, and I came to believe that I was worthless and didn't deserve to live. Binging comforted me and gave me something that no one else did. So you can see how the function of the suicidality differs based on the individual, and we really need to understand that to really meet our clients where they are and understand their perspective. So how do we conceptualize suicide and eating disorders? Again, this is a beautiful quote from Shneidman. Suicide is not a disease of the brain, it is a storm of the mind. Sort of the imperfect, perfect storm where all of these factors come together to place a person at risk for dying by suicide. So the conceptualization that we use for suicide and eating disorders is based on Joiner's interpersonal psychological theory of suicide. And what this theory says, is that, hold on one second. Sorry, I'm just getting over laryngitis, so I might have to take a sip of water every once in a while. Excuse me. So what Joiner's theory says is that 3 factors come together to place a person at risk for dying by suicide. The first is that psychological pain, which can also be referred to as burdensomeness. That's one version of burdensomeness, that burden of psychological pain. There are also other examples of burdensomeness, and these can include for clients feeling like people are better off without them, and so that might be sort of the classic way we think of burdensomeness in suicide. The other way that we sometimes see burdensomeness for our clients is the burden of recovery itself. And what I mean by that is I can see clients sometimes feeling daunted by the process of recovery. So for example, if they have trauma, let's say, and they find out that they really have to talk about this to be able to work through their trauma, that might feel impossible. And so that may feel burdensome to them. And so that hopelessness can kind of bog them down in a burdensome way. The second factor that's part of this conceptualization is thwarted belongingness. That's Joyner's term. I've never had a client say, I think I'm experiencing thwarted belongingness. But what they will say is they feel disconnected or they feel lonely. And that disconnection, isolation, loneliness is a very important factor in this makeup. And clients, I think about this, the experience of common humanity. Kristen Neff talks about that in terms of self-compassion. Individuals who feel suicidal often feel so alone, they don't feel like anyone else has been through this pain or would understand this pain. And that loneliness often is a driver in a suicide attempt. Finally, the factor that might be sort of the tipping point factor is what Joyner refers to as acquired capacity for lethality. And this factor has two parts. The first is an increased tolerance to pain, an increased habituation to pain. So you can see here in the picture, the way we measure that in our research is through an algometer that measures pain tolerance. And so there, that's a pressure point and how much pressure can a person withstand. And individuals who can withstand higher pressure there have a higher pain tolerance. The second component of that acquired capacity for lethality factor is a fearlessness regarding death. And so when those things come together, pain tolerance and fearlessness, that person would meet criteria for an acquired capacity for lethality. So those three factors would come together to place someone at risk for a serious suicide attempt, if not fatal. So this is what it looks like in action. So these two factors, perceived burdensomeness, which might be psychic, and thwarted belongingness, which might be another term for it would be disconnectedness. You can see this is a bigger bubble because many of our clients have these symptoms. I would say that a good portion of our clients have these symptoms. But it's this third symptom that together with these other two symptoms, this acquired capacity for lethality, that places a person at risk for a serious suicide attempt or a fatal attempt. So what would that look like, and how does that look in eating disorders? I often give a riddle at this point to ask the audience members, what does a military veteran, somebody with an eating disorder, and a veterinarian have in common? And what they, on the surface, it doesn't look like much, but what they have in common is that they all have an acquired capacity for lethality in different ways. So for instance, the military veteran, that person, that one's easy. Think about this, like that they're sort of at death's door in different ways. That's what these group members have in common. So for instance, somebody in the military, they're kind of up close and personal with death, and so in that way they may desensitize to pain, and they may desensitize to death and develop a fearlessness in that way. And And so individuals with eating disorders, this same thing can happen. How many of our clients have said things to us like, oh my gosh, I've been told 10 times over that I should have died. Nobody should be going around with a potassium level that low. And so in some ways they may desensitize toward death. And they also may be sort of upping the ante, so to speak, in terms of pain tolerance. So they are engaging in more and more purging behaviors or hard exercise, or many of our clients engage in self-harm, and they engage in more and more extreme versions of that, so to speak. So that would be an example of how individuals with eating disorders would be sort of at death's door, so to speak, and so that they would develop that capacity for lethality. Veterinarians, in fact, one of our colleagues, Tracy Whitty, is at Auburn University, and she studies in veterinarians the rate of suicide, the high rate of suicide. And so one of the theories as to how they develop an acquired capacity for lethality is that they're up at close and personal with death as well, in terms of euthanizing animals as part of their job. So those are some examples. And so I guess the bad thing about this acquired capacity, I think of it as a bucket. I'll often kind of use a gesture to create sort of this acquired capacity bucket, and all of the experiences that go in that to sort of desensitize someone to pain and death. You can't take those out of your bucket, but you can put a lid on the bucket so that you're not continuing to add to it. And so that is the way that I often think about it, and that those experiences are, can be added up in different ways. So those are the ways that these factors come together. So indeed, research has shown that there is a high capacity for lethality in eating disorders. There was a study of individuals who died by suicide that had anorexia, and they chose very lethal, clearly, but very violent means of their suicide attempt. And so this goes along with that idea that there was sort of this desensitization. In this study, the least violent method that was used was someone who had ingested household cleaners and her stomach ruptured. So this gives evidence to this idea of an acquired capacity for lethality. Individuals, actually, restriction sort of has some mixed results. Actually, one of the studies that we didn't find as much of a relationship with restriction as some of the other behaviors that go along with eating disorders in terms of their relationship to this acquired capacity for lethality. But there's some conflicting research here, but some that shows that severe restriction is associated with sort of that desensitization to pain and to death. Hard exercise. These are individuals who engage in exercise despite having injury, over-exercise, that kind of thing. And indeed, that's been found to be associated with acquired capacity for lethality and higher suicide rates. And then violent eating disorder behaviors such as purging have been found to be associated with that. So that's the conceptualization. And so understanding that conceptualization, it's important to know that our clients, when we get to the part about means restriction or means reduction, as we say now, that is an important aspect of putting a lid on the bucket of acquired capacity. Going back for a second, what's interesting is means reduction really seems to be where you get the most bang for your buck in terms of protection in that acquired capacity bubble. But actually research shows that where you can get most bang for your buck in decreasing suicidal ideation is through connectedness. And that always gives me sort of a breath of relief, because oftentimes just an interaction with the client, just establishing rapport in that first session can be a way to connect that can dampen some of that that suicidality. And so that is a good way to think about this. All right, so let's go into how to do a good suicide risk assessment. And I love this quote. This is by Shneidman as well. And so he says, actually, the quote is longer than this. He says, the effectiveness of my intervention rests on the answers to these two questions. How willing am I to be inconvenienced by a person's response to where does it hurt and how can I help? I think it's important to recognize that we are clinicians and we are human. I have to look at that human part of myself to be able to tap into doing good work with clients who are suicidal. So it is normal if it is 5 o'clock on a Friday and you were supposed to have you had tickets to see Hamilton or something like that, and you have a session with a client who tells you that they're suicidal. It is normal to be able to say, oh man, I can't believe I have to do this right now. That is part of being human. I have to be able to access and connect and validate that part of me to be able to connect into the other part of me that's so important right now, which is this is the most important thing that I will do today, or maybe even as part of my time as a therapist. This is, for this person, a matter of life and death. And so being able to kind of hold both of those, as one of my colleagues says, is important. So a good suicide risk assessment addresses all of these factors. Sometimes I feel like it's overwhelming to look at these, but we're going to go through them, and as part of our good assessment, we'll be able to address each one of them. One of the things that's important in this slide is realizing that formulating risk does include clinical judgment. There is an art form to this. So it is not, I used to wish that you could do like a little Wonkinator where you could type in each risk factor and this beautiful little ticker tape comes out that says, this person is moderate risk. Now you need to establish a safety plan. And there is no such thing as that. So even as part of following a template for assessing suicidality, there is clinical judgment that comes into play. And so what's important is for that is to just know that you need to justify your decision and explain why you did what you did and why you didn't do what you didn't do. And that is an important part of this. Also, an understanding in our assessment that we'll do taps into this, but understanding that risk factors are very important for sure, but they're often outweighed or tempered by protective factors. So for instance, if I'm a client, I may have had previous attempts, a family history, substance abuse, and childhood trauma. I may have all of those things, but I also have a pet that I'm really close to. I'm really close to my family, and I have good coping skills and restricted access to means. So those protective factors may outweigh some of those risk factors. So we have to look at those in combination. All right, so you will have this handout. And so if you don't have access to it now, we will get that for you. This is the suicide risk assessment that we utilize, and it's based on the SPRC, the Suicide Prevention Resource Center's risk decision tree or decision tool in determining suicide risk. So it kind of brings it all together to be able to formulate a level of risk. Now, here is the caveat. Currently, formulation of risk level, mild, moderate, or low, moderate, high, or imminent, is the recommendation for risk assessment. There is some talk through the American Association of Suicidology to move away from those risk level designations. And as we work through those, I'll explain why. I'm actually a proponent of moving away from those, because oftentimes that risk level does not determine what your intervention is. It's based more on specific factors that may be present in various risk levels. I'll explain that as we go. So this is an example of this template. So you'll notice that you would be assessing for a client the presence of 3 factors. I'm thinking, okay, good, yes, I can use this little arrow. Suicide desire, capability, and intent. So we'll start there. And so if you were assessing this on a client, you would go through these different symptoms to determine if your client has those symptoms. Now, some of these you can ask directly, and others you can gather from some of the things they say. It is amazing to me sometimes the script, really, that clients have that's very similar across clients. You'll hear clients say, I feel trapped, I feel alone, I feel completely isolated, I feel hopeless, I feel helpless. And when you have clients saying those things, you can mark them off as the client sitting there, so that you don't have to go back and ask them again. Capability, you can see this as well. So these are some of the factors involved in that. And then intent, you can see the factors there. What's important to note here is that you only need one factor in one of the categories to get credit for that category. And so that is an important takeaway. So for instance, this is the scoring. So if you had, let's say, going back, you just had psychache, you had psychological pain, and that's all you had in this column, but you then would meet criteria for suicidal desire. Let's say you had nothing in the capability column and nothing in the intent column. Then you would get credit for this desire, and you'd be in this low tier, this bottom tier, the low to moderate risk. Well, how do you determine if the person has low or moderate risk? It is the presence or absence of these buffers or protective factors. So let's say this client has many of these factors here: immediate support, social supports, she's planning for the future, she's engaged with the therapist. This was developed for telephone crisis workers, so that's why it says that. So if that person has a lot of these, then that outweighs some of that level of risk, so this person would have low risk. If the person had very few factors, and let's say even more so, let's say that they had very few of these, let's say they even had more, they had all of these factors, well, then that person may be more moderate risk. Now, if the person has something in the desire column and in the intent column, or something in the desire column and the capability column, then they're in this middle tier. And again, the presence or absence of protective factors in that last column would determine where they fit along this continuum. If they had many protective factors, they'd be moderate risk. If they had very few protective factors, then they'd have high risk. Now, if they had something in all 3 columns, they have something in the desire column, something in the capability column, and something in the intent column, it does not matter how many buffers or protective factors they have, they're still automatically high risk. Now, we use a 4th category that's recommended, which is called imminent risk. And these are individuals who are at risk for suicide right now, and they need hospitalization. So high-risk individuals are individuals that can often be treated at the outpatient level of care, or residential, or PHP-IOP. High risk does not mean call the ambulance. High risk can still be treated at lower levels of care if they're able to reduce access to means and able to follow a safety plan. So let's go through this as an example. So this is a client that we had several years ago, actually, who'd stepped down to us from a higher level of care where she had been hospitalized for a suicide attempt. And so when she came to us, she'd been there for 30 days. This was a private psych hospital, not like a 7-day or 5-day kind of hospitalization to stabilize. She'd been at Menninger. She stepped down to us after 30 days. And so when she came to us, she was feeling much better. She had no suicidal desire, no pain, no hopelessness, no helplessness. You can see along those lines here. She did have two attempts of two suicide attempts. They were both by cutting. She had no exposure to someone's death. Her grandfather had died by suicide before she was born, and so that is a risk factor. So I did note that there, but she had known that it was before she was born, so she was not exposed to it. And she also had many buffers. Her girlfriend, her brother, she had social support, she had planned for the future, that kind of thing. Now, what's interesting, though, with this client is that she only had one item in the capability column, and and she had many buffers. So some people might say that she should be low risk, but actually we scored her at moderate risk, and this is a good example of where that clinical intuition and clinical judgment comes in. This client had just stepped down to us from inpatient care and was going back to living at home where there was conflict related to her sexual orientation. And so that was one of the reasons that she'd said that she'd attempted suicide in the first place. And so going back home, we thought could increase that risk. So we put her at moderate risk. And so you can see that as an example of where that clinical judgment might come in. So a good suicide risk note includes, it would look like this. What are the indicators of suicidal desire? What are the indicators of capability? The indicators of intent? What are the protective factors? What's your overall assessment rating? And then what is your plan based on that assessment? This is an example note that for this client, and you can use this as a template for your clients. It looks long, but actually all it is going through each column for her and what where she met criteria and where she didn't, and then the plan based on where we had scored her. And so you can use this, like I said, as a template for your own progress notes. The other assessment measure that really might be helpful with clients is a measure that Dr. Mary Bartlett and I developed called a suicide timeline. Now, this would only be used for those clients who do have a history of suicide attempts. So, for instance, this client would have been a good example of using a suicide timeline. And so for this timeline, you basically start at a beginning age and work up through the current age, and you can include on this specific dates when the first suicide attempt was, and when the eating disorder started, what the purpose or the function of the ED is, the purpose or the function of the self-harm, the purpose or the function of suicidal thinking, risk factors, protective factors, reasons for living, reasons for dying. So this is what it looks like in action. This is the suicide timeline or suicide trajectory. This is a client, this is a different client, not the one that we had that I went over before, that said that when she remembers that some of her depression started when she was in the 5th grade, when she was 12 years old, and she was currently 22 years old when she came to us. She was diagnosed with her eating disorder when she was 19. She started cutting when she was 15. She was diagnosed with anxiety and depression when she was 15. Here are her reasons for living, her reasons for dying. Her self-harm, most recently, she hadn't been cutting in a while. Most recently, it was scratching. Her suicide attempts are listed here. Her first one was when she was 16 and she overdosed on aspirin, about 30 or 40 pills. It's important to get some details here without being gratuitous, but you want to get some details to see if the suicide attempts have increased in severity or lethality, because that does suggest some of that habituation or desensitization toward death that we had discussed. And indeed, this client is an example of that. Her first suicide attempt, she overdosed on 30 to 40 aspirin. Her second one, she overdosed on a variety of pills, and she spent 2 nights on a medical floor and 5 nights on psych. And so this was a much more severe attempt. She'd been to 3 treatment centers before she came to us, and actually what was interesting is nobody really ever talked to her about her suicidality, which goes to show kind of how this is sometimes something that's overlooked. All right, so let's say that we then have a determination of risk for a client. We have a good idea of what their history has been with suicide and where they are currently. So what do you do based on these risk levels? So first of all, this is sort of a cheat sheet. So you can use this as a way to guide you. So we'll start with no risk or low risk. So no risk or low risk without suicidal ideation. It's recommended that individuals complete a de-escalation plan. And as part of that de-escalation plan, why this is important is that many times people don't do a safety plan unless a person indicates suicidal ideation. And that's a mistake, because what if you meet with someone on a Tuesday and they, at that point, they don't report any kind of suicidal ideation, and you're not supposed to meet with them until the next Tuesday. Well, let's say that on Wednesday their wife asks for divorce. On Thursday, they lose their job, and on Friday there's a mass shooting in the world. And so those kinds of factors may come together to now place a person at risk, and they don't see you until Tuesday, and they haven't really gone over with you any kind of de-escalation plan for if some of those thoughts arise, or what to do if they feel escalated. So the de-escalation plan, a copy of that is included in your handout. And it would include also, if you become suicidal, this is what you do. Let's say, though, that the person is low risk with suicidal ideation. In this case, we would do a safety plan. Now, one of the things I really like to go over here, I'm finding more and more, I've been speaking on this for about 8 years, and when I first started speaking on this, almost everyone was still trained in doing no suicide contracts. That's what I was trained to do. So I always feel like that we should have a support group. All of us raise our hands if we've been trained to do that. But no suicide contracts or a no harm contract is not recommended. And instead, what's recommended is a safety plan. Well, so why is that? So no suicide contracts, or no harm contracts, as they're often called, have not been found to be effective in reducing risk for suicide. In fact, there's some studies that show of individuals who were in therapy who attempted suicide. When they got to the hospital, they'd assessed half of them had a no suicide contract in place, and so that doesn't seem particularly helpful. Also, there's some evidence that individuals that complete a no-harm contract report that it interferes with the therapeutic relationship. They'll say things like, I mean, I just did it because I just wanted to make sure my therapist sort of has a CYA, and I know that's why she's doing it, and so I sign this, and so then she's happy. The other thing, and this has always stood out to me, is that clients will violate a no-harm contract, and then the solution to that is just to re-sign it. And so again, I'm guilty of that. That's what I was trained to do. So I would have clients, sign, when I first started as an outpatient therapist, sign a, well, I'm in treatment with Dr. Siegfried, I will not hurt myself. And then I would have them, if they hurt themselves, I would have them sign it again. I mean, it's just It's just crazy. So that is not what's recommended. We used to think that, okay, well, maybe it's not that helpful, but maybe it really is a CYA, and so maybe if you have that in place, it will actually be helpful if you're sued after a client dies by suicide. And actually, there is no evidence of that. They have not been found to be protective in litigation. I would say, actually, since now the American Academy of Suicidology has recommended against the use of no harm or no suicide contracts, that having one of these in place would actually be harmful to you in a lawsuit. So, what's recommended instead? What we recommend is, not we, but it's also recommended in the literature, is a safety plan. And I've heard people go, oh, yeah. I mean, that's just a no harm contract with a better, that's, with a bow tie on. And that's not correct. A safety plan does not have anything in it anywhere that says, I promise I will not hurt myself. What it has instead is the things that you would do if you do have urges to hurt yourself. So it focuses more on what you will do versus what you won't do. It also is very collaborative and is done with the therapist. I recommend even, sitting side by side with the client and completing this together, and so it's given its value as a very important document. This isn't something to say, hey, complete this safety plan on your way out. There's one, in the foyer. This is something that's done collaboratively. And it focuses on how to increase to increase that window of tolerance for emotional pain and creating a life worth living. So this is an example of a safety plan. And actually, this is what ours looks like. But there's an example used in your handouts that's the SPRC version. That you can use our example if you'd like, or you could use the SPRC version. And so you'll see here, these are the things to do when I feel distressed. This is how I can create a safe environment myself. And then the research shows that if you can, during that time of constricted thinking, if you can think of a reason to live during that time, that it can sometimes pull a person out of that constricted thinking a little bit, because they can't access those reasons for living during that constricted thinking. So here's an example of an intervention to do with reasons for living. So you can give clients a note card and they can list out all their reasons for living. One of the things that's important here is for the client to come up for their reasons for living. It is never helpful for you to tell the client all the reasons they should live. They're hearing that all of the time outside of your session from well-meaning family members and loved ones. So it's important for them to come up with it. And you can see this. This is an example from one of our clients that he'd come up with. And these are very specific to his reasons for living. I want to see my son grow up. I want to graduate from college because I have courage to live. You can see some of these reasons. And so what he was able to do was to pick the most powerful reason for living for him and put that on his safety plan. And for him, that was to see his son grow up. Now, what if a client is at moderate risk? After you've done that risk level assessment. If a client is at moderate risk, you're still going to do the safety plan just like we did before. In addition to this, you're going to do means reduction. We used to call this means restriction, where we would restrict access to means. And actually the terminology has changed because we found that you can actually just reduce access to means. And just by a means reduction, it decreases risk. So with means reduction, you want to ask a client about their access to means. And so for instance, when I talk about reducing access, examples of things that we do here oftentimes is that we would say, hey, it would not be good for you to have access to all of your lithium. And so the entire bottle of lithium, for you to have that would not be helpful. But if you can feel safe, with a 3-day supply, that would be an example of means reduction. So it's not taking your lithium completely away and having having someone administer it to you, but just having reduced access to means. The same may be true for guns. Guns, we know, are the number one killer in terms of suicide, and so reducing access to firearms can be very important. And again, so it doesn't have to be get rid of all of your guns, go sell them at the pawn shop. It could be you have just temporarily have your grandparents keep your guns, or just you can even keep your guns but not having access to the bullets, that kind of thing. I worked at the VA, and so you definitely don't want to get into an argument about access to firearms. That's where I learned that, because I would want to say, like, let's just get rid of your guns completely and take them to the grandma's house or something. And that you could get sort of into a power struggle with that. And actually what research shows is that's not necessarily necessary to completely get rid of them. I mean, try to think about having that conversation with someone who just came back from Afghanistan. I mean, he also feels safe having his gun. So how do we help them feel safe, but also reduce access to doing something that might hurt them or kill them? If a client is high risk, you're going to do, and again, this is why you see that some of these interventions are very similar. If you're moderate risk or high risk, you're going to do the same things. But when someone is high risk, you want to rule out imminent risk. And so if a client is at imminent risk, that client needs to be monitored at all times until the ambulance comes or until they can get to the hospital. I often talk about the hospital to clients as the ultimate example of means reduction. I want them to understand it as a place of safety and not a place of treatment necessarily. I mean, although safety is a treatment, but oftentimes clients are misinformed that when they go to the hospital that their suicidality is going to go away. And I want to make sure that that's not what they think, because then they might feel very hopeless when they leave. And one of the things we know is that suicide rates go up by 200% after a client leaves the hospital. And from my perspective, that's partly due to the fact that clients don't understand the purpose of hospitalization, which is just to create safety until the client can create that safety for themselves, or just to get medication on board and regulated until the client can create some safety for themselves. So these are some of the ways to make a distinction between imminent and high risk. These are reasons that you might want to hospitalize a client if the client's psychotic or intoxicated, they can't follow their safety plan, they are unable to agree to means reduction, they are planning on using substances, which is associated with a higher rate of suicidality when they leave your office. And so these would be reasons that you might consider hospitalization. So this is just somewhat of an overview. I feel like in some ways sort of a quick and dirty overview on what to do with clients who are suicidal and how to assess for that and how to intervene. I want to be able to answer some questions. I do realize that we only have a few minutes for questions, but I will also be glad to be available to answer questions after.
Thank you, Nicole. I love this last quote. Okay, first question. How do you help a client to let go of shame if they had an attempt, especially if they have a family?
Oh, that's a great question. And shame is such a strong force in our clients with suicidality. And so, you know, we do a lot of work with helping clients develop compassion for where they were when they made that attempt. And in fact, I didn't go into this as much as I could have actually, one of the myths about suicidality is that it is selfish. And actually, clients, when they're suicidal, they think this is the least selfish thing they can do. Now, clearly, they're in that constricted thinking, and so they're not thinking clearly. But being able to help the client understand that might be a way to diffuse some of that shame, that the place they were coming from was that they really did think their family would be better off without them. And so that's a place of confusion, and so that can help hopefully develop some compassion for themselves and where they were in that process. I talk about that a lot, you know, that when you can develop compassion for an earlier version of yourself, that, or a younger version of yourself, that really can diffuse shame.
Is there any information or theory about why those with eating disorders tend to use more lethal means of suicide? Usually not as typical for men as with, or for women as with men.
Yes, and so that's the theory that I was talking about, that there's this acquired capacity for lethality, that in eating disorders they continue to sort of up the ante. So you may have started off with just purging once a week. Now you're purging, you know, several times a day. And so each time you're upping the ante in terms of your behaviors, you are also desensitizing yourself in terms of pain. And again, this sounds dramatic. It is dramatic, and stepping one foot closer to death, because now it's, if you think about cutting, for instance, people often start with very superficial cuts, and it gets more and more severe. And so that's one of the theories as to what happens and how these individuals with eating disorders end up making very violent, lethal suicide attempts.
That was actually our last question.
Great.
Yeah. So actually, before we go, I just want to let you all know that our next webinar is November 8th. From 12 to 1 Central Time, and the topic is Hunger Fullness 911, Nutrition Therapy to Disrupt the Binge Cycle, and that's with Tammy Beasley. So you can register on our website under resources, and it will drop down and give you the option to click on webinars. Okay, Nicole, anything else?
No, that's all I have. My contact information is here on this last slide, so please contact me if you have additional questions.
Thank you so much. Have a good day, everyone. Bye-bye.